Hello, everyone. Welcome to today's Spotlight series. My name is Dr. Tejal Ramaiya. I'm a physical therapist and owner at Body Moksha Physical Therapy in Chatham, New Jersey. And today we have a very, very special guest, Dr. McGue, who's an OBGYN at Summit Health. She's also a menopause specialist. And I'm so excited to have her on this Spotlight series today because we get so many questions from women about menopause and who to see and what to do. And it's so hard to find support. So I'm happy to have you. Thank you so much for taking the time and being here.
Thanks for having me. I'm happy to be here.
Yeah, I'm excited. So tell us a little bit about, I know you're an OBGYN, but like what's your background and, go into a little bit about what made you kind of more interested in menopause and specializing in that.
Sure. So I went to med school at Rutgers in New Jersey, and then I did my residency in OBGYN at Atlantic Health in Morristown, New Jersey. And then after I joined Summit Health, which it was one of the groups that I worked with during residency. And in my first year at Summit, uh, they had me present to the whole internal medicine department about menopause. Before then, our training is fairly limited about menopause in residency, so I was not at all experienced in it, nor had much exposure. We spent 4 weeks with a menopause specialist in residency, but even that was fairly limited. So it was like one day a week that she did menopause. So a lot of it was learning on my own. And so when I presented to the medicine department, it forced me to learn and be up to date on menopause. Um, and, and then the whole medicine department started sending me all of their menopausal referrals.
Mm-hmm.
And that was a few years ago. And since that, really, menopausal medicine has boomed and it's so popular in social media. And there have been a lot of uh, newspapers, New York Times exposés about the need for menopausal medicine. So I've stayed up to date on it and been very interested in it. So it was kind of forced upon me, but I
But there's also like such a huge need. And I mean, I don't know if you have insight on this, but like, why do you think it's become a bigger topic more recently? Is it more because women are just more aware of their health? Is it just there's just more social media awareness? Is it more because of research studies that have come out?
yeah, I think it's pretty multifactorial. There's one, the generation of women who are aging and reaching menopause is has grown. So all the baby boomers are really in the last era of baby boomers are hitting menopause. And then the New York Times wrote this really wild article about menopause, and I think that really started all of the like social media awareness online, as well as a few like gurus in menopausal medicine that started to take traction. Um, and finally, I think, even 2 weeks ago, the black box warning was just taken off vaginal estrogen cream. And so many people are less afraid of the negative side effects.
Mm-hmm.
Whereas, all along, OBGYNs knew, okay, this vaginal estrogen isn't causing breast cancer, but obviously, if you get a prescription and you read that it's going to cause breast cancer, you're not going to use the medication. So, I think, the awareness is amazing. And when
Mm-hmm.
things kind of take traction on social media, then they keep going. Um, so many patients are seeking uh, practitioners, but out of pocket. And I
Mm-hmm.
think the greatest part about all of this is now finally you can go see a doctor with your
Mm-hmm.
insurance and address your concerns too. So it's
Yeah. Yeah, no, that's true because it's just been so hard to find someone that is well versed in it. Like, have you noticed that any of your other colleagues are learning more about like menopause and specializing in it? Like, I know that Summit Health just recently opened like a menopause center. I'm not sure what they
yeah.
call it. So I know that's relatively new. And like, how
Yeah.
many people work there? And like, how does that, like, is it easy to get appointments?
So there's five of us that rotate through the Menopause Center at Summit. It's in New Providence. It's
Mm-hmm.
four OBGYNs and then one new nurse practitioner who has her menopause certification from the Menopause Society. And I think we opened it about a month ago.
Mm-hmm.
And now, I mean, it's so popular. Now
Mm-hmm.
there's like a giant wait list to get an appointment. Um,
Yeah.
but the other aspect of it is, I have a practice in Florham Park, and the other four OBGYNs and nurse practitioner do other things too. So you don't necessarily need to have a menopause center visit. You can see one of us in our office time. The setting of that is really nice though, because it's like, we're sitting around a coffee table discussing and it's more relaxed
Oh,
than,
that's what an appointment would look like?
yeah, yeah,
Wow. That's really
yes.
cool.
So it's more like conversational than, you sitting at an exam table and us just having a brief discussion during your annual visit. So that's
Mm-hmm.
been really nice as a
Yeah,
provider.
that's really cool because I know when I initially made my appointment to see you, I did ask on at the front desk about the menopause because I said I have some menopause questions too. And they said that I would have to make a separate appointment for that. So then I was like, you know what? I need to get my annual. Let me just set that up. And I was so excited that I could ask you my questions, like I didn't have to wait another 2 months.
Yeah.
So, like, I mean, either way, the main thing is you want to get your questions answered. So I think it was the fact that, like, you could do that in your annual visit, if you just have some brief questions is really, really nice. So you can get
Yes.
started. Yeah.
Yes, and I certainly don't mind talking about anything during the annual visit. But sometimes a menopausal visit can be quite lengthy, and people have a lot of concerns and symptoms to address.
Hmm.
So to get all of that taken care of in the annual visit can be challenging. So having the center and just talking about menopause, I think like patients are able really to speak more to their symptoms. Often people have
Hmm.
like quite a long laundry list of things to discuss, and
Right.
it's more casual than okay, and we have to do a breast exam and a pap smear.
Yeah, no, I agree with that. I think that if you have, and that would be the recommendation that you would make during a visit if someone had like a lengthy, like, it would be really good. Yeah, that's really cool. I love that.
Yeah.
Tell us a little bit about, you mentioned how HRT's been more of a conversation that has come up more recently in the past few years. There's so many different options. Can you tell us a little bit about some of the options and how you personalize treatments to different people depending on certain situations, like just briefly?
Sure. So, usually I first go through what kind of symptoms people have. The more common ones are hot flashes and night sweats, but people certainly have some of the more uncommon symptoms. So, insomnia, brain fog, joint pain, frozen shoulders, one of them. That's probably something you guys see plenty of.
I
And
had that, yeah.
itchy ears is one. Um, and so I go through what kind of symptoms patients have, and then depending on their medical history and risk factors, hormone replacement therapy could be a solution. And then we have other treatment modalities like Veoza or paroxetine, which are non-hormonal options for people that have contraindications. Um, as long as they don't have a contraindication, and the contraindications to hormone replacement are really, do you have a history of a blood clot or stroke? Or are you more than 10 years out from menopause? Or do you have a breast cancer? So pretty simple screening.
Yeah, yeah.
And then I typically prescribe the way that is recommended by ACOG, which is American College of Obstetrics and Gynecology. And that's an estrogen patch, transdermally absorbed. You put it under your underwear line. And the reason I give estrogen with a patch is it skips your liver. So it bypasses your liver metabolism. So you're not getting cholesterol issues or liver function abnormalities because those things also arise around menopause too. So we'd rather not have it be the fault of the patch and have it just be physiologic then. And
Mm-hmm.
then whenever you take an estrogen, you have to take a progesterone. So the best way it's absorbed is orally, which is in micronized progesterone. Um, that protects your uterus. So if you take estrogen without progesterone, you will get endometrial cancer. And
Wow.
that's not something that's that talked about. All birth control pills have estrogen and progesterone in them. And then hormone replacement therapy has to have both of those things as well. So I find many people, though, with the progesterone orally sleep better. So it's nice to
Mm-hmm.
have that additional pill to take right before bed.
Mm-hmm.
If people say, oh no, I can't ever remember to take a pill, or that pill makes me really, really drowsy in the morning, then you can do a patch with estrogen and progesterone.
Mm-hmm.
Um, and then there's also pills that have estrogen and progesterone too. And then finally, what's become quite popular, which is a great thing, is testosterone treatment.
Mm-hmm.
It's not FDA approved, but there have been some huge research studies that have supported testosterone treatment for hypoactive sexual desire disorder or low libido.
Mm-hmm.
And this is even in the last couple of months that it's become at the
Oh, wow.
forefront, and I've started prescribing it. Um, and it's a testosterone cream. It's just 1/10 of the dose of the male dose. So all of those things are available from your OBGYN. It's just a matter of their comfort in prescribing them.
So you mentioned you can do the estrogen and the progesterone as a pill. Like you could do the estrogen as a pill with the progesterone.
Yeah.
Why would you prescribe the pill versus the patch? Like it's
It's
just if
really,
you forget, like
yeah,
if
I'm
you
sorry.
forget.
It's really for the liver function abnormalities.
Gotcha.
That's
Okay.
that's
The main.
essentially the only reason. I think some people really like taking a pill every single day rather than taking a patch off every 3 days.
Mm-hmm.
Because the week is seven
You
days.
forget. Yeah,
It's
you
yeah,
forget.
and it's annoying when it's not something you do every day. So I
Mm-hmm.
certainly have people that take the pill every single day, and it's just something that gets monitored. Not even from my standpoint, like I just ensure that patients have a primary care doctor because with your care doctor, they'll do your liver function and your
Mm-hmm.
cholesterol function annually. So as long as that's stable, then it's fine.
Okay. All right. Cool. You mentioned about birth control, and this might be a silly question, but it's just interesting that there was such a big like scare about, taking estrogen and progesterone in perimenopause, but then why is everyone okay to take it as birth control?
Yeah, that's not a silly question. So I'm sorry, birth control pills have a much higher dose of estrogen and progesterone than hormone replacement therapy. So the lowest dose of a birth control pill is 10 milligrams a day. And I typically, I don't have many patients that are on a higher dose than 0.05 milligrams of estrogen transdermally per 24-hour period. So you can see that it's like a 20th of the dose, even less, than you're getting with a pill. And the
Hmm.
reason that's the case is for women who aren't menstruating, they don't need that much estrogen. In fact, too much estrogen can be um, counterproductive and could cause your uterus to start proliferating and you get another period. And after menopause, you really shouldn't be getting more periods. That's
Hmm.
that's like a light switch off in your doctor's head, like, oh, we need to make sure they don't have a cancer going. So it's a much, much lower dose. So the transition from a birth control pill to hormone replacement therapy, that's like a common discussion in the office is okay, we kind of have to factor in how old the patient is and when their mom went through menopause to determine, okay, should you come off your birth control pill now and we can transition you onto the hormone replacement therapy if that's what you want.
Okay. That's interesting. But there's no fear for, you know, taking birth control pills, but there's a fear in women for being on HRT.
Yeah. The reason that is there was this Women's Health Initiative study that was done in the early 2000s
Mm-hmm.
where they gave 60-year-old women estrogen, so hormone replacement therapy. And they had to stop the study because women were getting heart attacks and strokes.
Mm-hmm.
And that's really when hormone replacement therapy got shut down. So many people were just terrified of it. And, since that time, that study has been disputed because they were giving 60-year-old women estrogen who hadn't had it in their body in 10 years. And
Oh,
estrogen is,
right, the age.
yeah, is
Okay.
hypercoagulable. So, of course, these people were having strokes or heart attacks. Not of course, but that's why.
Yeah.
So when those studies were repeated on people less than 10 years since menopause, they weren't seeing those side effects. So that's really the difference and why people were afraid of hormone replacement
So
therapy.
it's more the 10, that's why you guys, it's a contraindication to prescribe HRT for anyone who's post 10 years menopause.
Yeah, to initiate it. But actually now patients can start, let's say someone started a year after menopause. We don't have an end date. It used to be
Mm-hmm.
you tried to discontinue them within 10 years because of that big study that was done. But now we're seeing that that's not actually true. It's just from the point of no estrogen and then 10
Mm-hmm.
years later. So I think the studies and the research are going to come out in the next few years, and it's a good time to be starting HRT because we're
Mm-hmm.
going to see the benefits of when to discontinue or not discontinue it at all. And there certainly are benefits to your heart and your bones by being on it too.
Yeah, and that was actually brings me to my next question about preventative medicine. And I think that that's such a big part of HRT. The symptoms I had were pretty mild, and I could have just been like, oh, okay, like I had frozen shoulder, do some PT. Like I didn't have major symptoms. My sleep is fine. I don't have night sweats. I don't have brain fog. But like, I could tell just being self-aware that, I felt like my inflammation was a little higher. So like that's why I had a conversation with you. I don't know if that's something the average person would do, but my question is more, I feel like, it's important to start HRT more because of prevention. And as soon as you start to feel like your hormone levels are starting to go down, the earlier you start, the less bone loss you'll have, the less cardiovascular negative consequences you'll have, and all of that. So I don't know. Can you talk about that a little bit? What do you think is a good, how do people know when to start, and how can, I guess for, we talk to patients all the time. And when I bring up HRT, like a lot of people kind of just put up a wall.
Yeah.
But, how do you have a discussion about how this is so important for prevention and longevity?
Yeah, good question. Um, So it hasn't, we haven't had the guidance from ACOG, which is the governing body of OBGYNs, about it as a preventive treatment. There certainly is research to support it helping with your heart and your bones. And so in the absence of any symptoms, your OBGYN is cautioned not to initiate HRT. So, is it a preventative medicine? In my opinion, yeah. And I think that data will get there. Um, there's no ideal dose that's going to prevent osteoporosis. We know it helps with prevention of osteoporosis, but there's not an ideal dose. So is it 0.025? Is it zero point 0.5? I don't know yet. And I think that probably will figure that out at some point.
Mm-hmm.
Most people aren't willing to start a medication unless they have a symptom. So it's not right now, it's not prescribed for prevention and treatment of something like if you don't have any symptoms, it's not right now prescribed for that. Will it be in the future? Maybe. Is it helpful for people? Yeah. I in my practice, I took over from a physician who was very pro HRT during the era where it wasn't the case. And so I have many patients that have been on HRT for 20, 30 years. And I can't say for certain that like this is research driven that they don't have osteoporosis, but they certainly are in very good health. And I think all of that data is forthcoming.
Mm-hmm.
Would I start it on someone who just wants to, get ahead of something, with caution? I would
Mm-hmm.
definitely have the discussion, we don't know for certain
Mm-hmm.
if this is going to help you. There are risks to starting an estrogen and it is hypercoagulable. So it's really like a patient doctor discussion more so than no, absolutely not. You don't have any problem. I'm not starting you on it. But I
Mm-hmm.
think with any medication, patients have to know the risk.
Mm-hmm.
How much risk is there? Without risk factors, not so much. And I'm sure many people out there are seeking help from like a wellness specialist and paying out of pocket for very similar treatment. And
Mm-hmm.
I think it'll be just an interesting thing to see in the next like 5 to 10 years, like
Yeah.
how our prescribing patterns change.
Yeah, that's true. Do you think a lot of more OBGYNs are kind of starting to incorporate, learning more about menopause and
I think it's become quite polarizing, actually.
okay.
There's a group of us that like have embraced it and it's become a big part of our practice. And then there's others that are like, I'm not learning a new trick right now. I have all my skills and I'm not
Yeah,
willing to like keep learning this new trick. So, um, and I think that's with any medical specialty when
I
a
agree.
new something comes out.
Hmm.
Our, you know, one of my nurse practitioners and I are like, wow, we would be rich if we just started a menopause clinic and took cash only. But that's not why you go into medicine. You go into medicine to help people, and people are already
Right.
paying for their health insurance. So really, they shouldn't be paying out of pocket for these things. Um, I think many people have, like the younger OBGYNs, I'm clearly younger, um, are embracing this because this is the future.
Hmm.
And I think when you find a younger OBGYN, they might be more willing and knowledgeable, or someone that's going through menopause themselves, because our own
Yeah.
experience triggers, what we are interested in too.
Yeah, that's true. That's true for sure. What are some of the questions, like common questions that women you see tend to ask you or topics that come up during a visit?
Um, Everyone wants to know about the breast cancer risk with hormone replacement therapy. And I've got my spiel down, so you've heard the spiel before. But
Hmm.
I say, and this is the research, that HRT does not cause breast cancer. Someone with breast cancer, I'm sorry, someone on HRT and someone not, they get breast cancer at the exact same rate. So it does not cause breast cancer. They also die at the same rate. So whether or not you're on HRT, you're not going to die from breast cancer more often if you're on it than not. So it doesn't give you it and it doesn't kill you from it.
Hmm.
The difference is at diagnosis, it can be more advanced when you're on HRT. And the rationale that I go through with patients is this: breast cancer is often hormonally driven, so it's either estrogen or progesterone. There's another factor in there too, but those two things are quite common. So if you have a breast cancer that's responsive to estrogen and progesterone, uh, and you're feeding it extra estrogen and progesterone, of course it's going to be more advanced. Um, but I've already said that it doesn't kill you from it. So you might have to, have a mastectomy versus what it was going to be a lumpectomy, or you might need chemo and you weren't going to need chemo, but you won't die from it. So that's, I think, the where people decide, "Ah, I don't want to do that, or I'm okay
Mm.
with this risk." So I think that's really the most important question that people ask, or if they're high risk for breast cancer. Um, And then I tell them, if it was me and I was suffering so much, I'm in a doctor's office talking about hormone replacement therapy, it's worth a try to see if it makes you feel better.
Yeah, I mean, I've heard from so many women how it's like been life-changing for them to get rid of their symptoms and being able to sleep. I mean, if sleep is one of the issues that you're having and that's one of your symptoms, I mean, that in itself, lack of sleep is going to affect your mortality. So, like,
Yes.
doesn't it make sense to get a good night's sleep for years and years and
Yes.
years to help you to live longer? So
Yes.
yeah,
The other thing
um,
people want to talk about is weight gain.
yeah.
And it has never been shown to be a treatment for weight loss. It's not a GLP-1. But if you're not sleeping, like we just talked about, and you're up half the night with hot flashes, and you're sweating all day, and your brain's not working, and you're fatigued, you're not exercising, you're not making good
hmm
decisions. You're probably like your cortisol is probably high, and that's super hard to
hmm
test. But once all of those things get under control, people start to eat better, they start to exercise more frequently, mood is elevated. So that in itself can cause weight loss, but it's
hmm
not like a wonder drug like some of these GLP-1s are.
Yeah. Yeah. No, that makes sense. I mean, I do know women who have gone on HRT for the purpose of like hoping they'll lose weight, but I think that making lifestyle changes first can make a bigger difference, but like it can help support, being able to exercise and eat better just because you're sleeping
Yeah.
better. Yeah.
Yeah.
Do you any other like misconceptions or myths that, like you have heard or that you know of just being in your profession around menopause or perimenopause or HRT?
Um, so historically, it wasn't prescribed to women until they went through menopause and had no more period for a year.
Mm-hmm.
And now we're seeing there's some benefit for some people starting it when they're in perimenopause. And the average age of menopause is 51, but perimenopause can be plus or minus 10 years from that.
Mm-hmm.
So, I have started prescribing it to perimenopausal women and seeing if it makes a difference for them. Um, Perimenopause is, challenging. We don't have lab work to essentially say, yes, you're in perimenopause. You kind of have to do a little thinking on what the labs show because the range of normal and estrogen is so broad from the lab that we can't say, okay, yes, you're perimenopause. You have to kind of compare a bunch of things to one another, a bunch of different lab tests. So the perimenopause discussion has become very popular. And I've found that there are many patients in their 40s that want to be started on estrogen as like oh, I'm fatigued and I'm tired. Well, you kind of have to tease out is that because, in your 40s, your kids are young, you're not sleeping well,
Mm-hmm.
you're kind of like hitting the peak in your career, so you're really busy with your job, or now your kids are in school and you were a stay-at-home mom and now you're struggling to find like your place in life. So
Mm-hmm.
I think the perimenopausal discussion is actually more challenging from a physician standpoint to really isolate, is this a hormonal problem or is there
Mm-hmm.
something else going on? For me, it's again just like a risk factor thing. Am I
Mm-hmm.
harming you by starting you on this? If my opinion is no, then I'm okay starting someone on hormone replacement therapy and I have them come back in 3 months and see, are you feeling better or not? Most of the time, people have like, oh, yeah, I'm feeling a lot better, but I need a little bit more. Oh, no, this is perfect. And the people
Mm-hmm.
that say, no, I have no relief, nothing got better, then I become a little
Mm.
more wary, like, am I actually treating the problem or is there a different problem?
Right. No, that makes sense. So how often do you recommend, because some of those things can be also like lifestyle related, right? Like how well are you eating? Like what's your nutrition like? Like, obviously alcohol intake can affect your sleep and your heart, all the things. Are you exercising, fiber intake, like all of the stuff. So how often do you recommend lifestyle changes first before doing HRT, or do you recommend HRT if it doesn't help, then have the lifestyle change conversation, or I don't know.
Usually, I try the lifestyle discussion first. Like, are you exercising? Are you eating well? Are you making healthy decisions for yourself? What's your alcohol intake like? And actually, in our practice, we have like a screening sheet that patients fill
Mm-hmm.
out before I even see them. So that has, what are your symptoms? And then what's your alcohol consumption per week? And I've actually found, like, at least my patient population, they've really tried the lifestyle modifications first.
Mm-hmm.
It's not often where someone comes in and they're like, I don't exercise and I eat whatever I want and I want
Mm-hmm.
this. So most people want to do the non-intervention route first and they've tried it and then they come see
Mm-hmm.
me. But that's like my patient population. I think most culturally, most people don't want to be on a medication unless they need it. And
Yeah.
there's this huge trend moving towards like natural treatments of everything.
Mm-hmm.
So it hasn't been too big of a problem. I think people have tried those routes first.
Mm-hmm. Yeah, that makes sense. So what are some of the things that you do just professionally to kind of stay on top of, I mean, things are changing probably
Yeah.
so fast, I would think, with the medications and treatments available and all of that, the research. How do you stay on top of it all?
There's a group called the Menopause Society, and
Mm-hmm.
they put out so much information pretty frequently on, changes in the field. And so, and then there's a couple other OBGYN related informational resources I have. And a few of them just send you emails every day about updates in the field. So not specific to menopause, but their research studies, those kind of things. So like I
Mm-hmm.
continue to read every day about changes
Wow.
because medicine's changing every day.
Yeah.
So, and if you're not up to date, you could harm someone, but also you're not really helping people if you don't know
Mm-hmm.
what's happening. So those two things, certainly. And then we in our group, in our menopause center group, keep each other up to date too. And we have like a bunch of different communication modalities, email, text message, like, oh, I have this patient, this is what's going on with them, or did you guys see this
Mm-hmm.
study? So there's a bunch of us that are really making a lot of effort to stay on top of it.
Very cool.
Yeah.
Awesome. So what's the most rewarding thing about working with these women?
Oh, it's amazing when they come back at the 3 month mark and are like, I feel great. I don't want to divorce my husband anymore. I'm
That's
sleeping
crazy.
at night, I have symptoms, I don't feel rage, I'm successful at my job again. So it honestly, that like 3 month visit when they have success and are feeling like themselves, it's amazing. And it's not a hard thing to prescribe. And insurance is covering it for most people too.
Yeah. Yeah.
Oh my God.
Are
So
there certain insurances that don't cover HRT?
historically, they didn't.
Oh, yeah.
And in the last year, most people are getting it covered. The most out of pocket I've seen for like a monthly prescription is like 80, $90, which
Hmm.
for the most part it's like 15 per person.
Yeah.
Yeah, that's the best. And that's an easy one
Yeah.
for me. You show up and you're happy and that's great.
Yeah.
Yeah.
Yeah. Oh, that's good because I mean, it changes your life that much, sleeping better. Like, I mean, it changes your whole life, but right, how you interact with your husband, your kids, your job.
Yeah.
Like, that's like literally, I mean, obviously life changing, but that's amazing.
Yeah, there's been
Um,
not a small amount of patients that are like, I want to know, like, I want to divorce my husband. He's driving me insane. And I know there's nothing wrong with them. I just feel
yeah.
rage. And
Wow.
yeah, I'm like,
I
please.
actually remember my mom going through that
Yeah.
like years ago, and she was just like either really mad or really sad.
Yeah.
And she was like in her early 50s, and like, she started HRT actually, whatever it was at that time. I don't
Yeah.
remember.
Oh,
I was
that's
in high
helpful.
school. Yeah.
Did it
Um,
save that?
yes, it did help her a lot. So like, and thank God she started it. But yeah.
Yeah, I'm
But
like,
I
don't blow
remember,
up your life. Let's
yeah.
try this. Yeah.
Yeah, that's amazing. Because those like changes. you get so many changes at this point in your life, in your like late 40s, early 50s. Your kids are going to college, like your relationship with your spouse changes. I mean, you're going through perimenopause. All of the things are happening. So like the more you can like manage your emotions,
Yeah.
the better.
Yeah.
All right, cool. So is there anything else that I might have not asked you that you want to add or you
Um,
want women to know?
I guess one thing we didn't touch on is, like the vaginal dryness aspect of menopause. So, um, and I figure that your network of people is comfortable
Hmm.
discussing that too,
Yeah,
especially
100%.
in pelvic floor PT.
Because that we see that a lot in
Yeah.
as a symptom. Hmm.
So the reason you get that is without estrogen, the cells in your vagina are just not as supple and they become more dry. And there are treatments just for that symptom of menopause, which is vaginal estrogen, and it works beautifully. And then, if you are having the systemic symptoms too, sometimes just doing the patch and the pill or the pill or whatever route that you choose can help those symptoms as well. So you can kind of ditch the vaginal estrogen. But
Mm,
vaginal
okay.
estrogen is safe. And with that black box warning removed, I think people are really more comfortable using it.
Hmm.
And that helps not only with symptoms of dryness, but it helps with lubrication during intercourse. And which again helps your relationship with your partner when it's not uncomfortable to engage in like an important intimate part of a partnership um,
Hmm.
can certainly help your relationship and yourself. Like you should be
Yeah.
able to enjoy
I
that the
mean,
rest of your life.
right. You just feel more confident about your relationship, and obviously women want to feel attractive. So
Yeah,
all yeah,
yeah.
all of the things. Yeah. No, that's good. I'm glad you added that because yeah, we didn't touch on that at all. Is there any like, I know we talked about like, the negative aspects of HRT maybe, that people thought was true, but what are some like mild side effects that someone might um have if they start
Yeah.
HRT?
Good question. Anytime you start an estrogen, birth control, HRT, some people get breast tenderness. If you like around your period, people report breast tenderness. So starting HRT, you can have that. And that symptom usually dissipates as your body gets used to it again. And then estrogen can cause like a headache too. Um, so those and then the most concerning, which is something you should tell your doctor right away, is if you start to have vaginal bleeding, because then perhaps, you're on too high of a dose of estrogen. Because once you
Okay.
don't have a period, you really shouldn't be menstruating anymore. The progesterone is fairly limited. There's not so many adverse effects to it. Patients report being sleepy, which is why you take it at night. And I do have some patients who report, I feel bloated or I feel like, I look bloated. Um, some people say, the fatigue lasts the whole day. So if those
Oh
things,
wow.
yeah, everyone's in different, everyone's
Hmm.
response to medication changes. So if that's the case, I can titrate the dose around a little bit too. And then
Okay.
the other option, if the progesterone's really not well tolerated, is something like an IUD. So that protects your uterus too. And it's not harmful to have an IUD even postmenopausal. In fact, some of an IUD can be a treatment for precancerous cells in your uterus to avoid
Oh,
surgery. So there are different things that we can do. That's why I have people come back after 3 months because those some of those symptoms we can fix a little bit.
yeah. And then, it just helps the patient be more comfortable because when
Yeah,
you start something like a new treatment that's every day and going to be long term, you
yeah,
want to make sure you're checking in with your doctor just to make sure you're feeling good about it. So,
yeah.
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 Very cool. Awesome. So this was really, really, really informative for me. I
Great.
mean, and I know that I've already had a conversation with you about this, so really, really helpful. Anything else you want to add?
Um, well, for your profession, pelvic floor therapy is super helpful for, not just menopausal women, but people through all stages of their life. So you're doing great work too.
Thank you. No, it's really rewarding to be able to help women. I mean, women who are having pain with intercourse, like avoiding going out because they're not sure if there's going to be a bathroom available, because they have leakage. Like, I
Yeah,
mean, it's just life changing to be able to be more confident in your body. And I'm so happy that women are just more aware of all of the treatments that are available when it comes to pelvic floor PT, menopause treatment, like everything. It's amazing how far medicine has come in the last like 10 years
totally.
or
And
even 5 years.
yeah, even like two, it
Yeah.
has been so helpful to women. So I'm happy that this is a discussion that's happening and
Hmm.
thankful that our patients have options.
Hmm.
Historically, I think women are just like, oh, this is just how it is. And this is just what my life is now.
Exactly. Yeah, you don't have to live with it anymore.
Yeah.
So thank you so much.
Thanks for
So if
having
you are a female woman going through any of these life changes, if you have any of these symptoms, or you're just not sure if these symptoms are perimenopausal or menopausal, like definitely reach out to Dr. McGue. She's at Summit Health, um, a regular OBGYN annual appointment or part of what do they call the specialized group? Is it the menopause?
Menopause
Like
Center.
Center, and
Yeah,
that's in New Providence.
you got it.
So you can just go on the Summit Health website. What's the best way to
Yeah,
make an
or
appointment?
yeah, you can go online or you can give the any of the offices a call and they'll have the referral to there. Just
Okay, perfect. Very cool. So definitely you guys can reach out and it'll be really, really good support for you.
thank you
Thank
so
you
much.
so much. It was awesome, and I will talk to you soon.
Have a good holiday. All right.
You too. Bye.